For me when it's live. So hope all of you are having a nice holiday these days. So
Yeah, we are live on YouTube now. You can begin.
okay, thank you, Mansi. So so welcome everyone to the 12th Fine Neurophilia series module. So this is actually regarding diseases of peripheral nerves. So we are dealing with a very wide, vast topic, but based on this vastness of the topic, the yield from this topic is very less. But before starting the topic at the outset, I would like to thank the whole fine team for giving me this opportunity to take these sessions for all the MD medicine as well as the pediatric aspirants, and also the MBBS students who will be watching this in the YouTube video, because the competitive exams have become more tougher, emphasizing on all the advanced aspects these days. So with this, I'll go to the topic proper. We are doing this session based on an MCQ model. That is a 20 questions. We'll be trying to cover portions within the peripheral nerves. So in this session, what we intend to do is not to cover the entire portion, but to make you read the books, basic books like Harrison and Bradley, which are the basics for the DM entrance exams. So with that, let's try to solve this question. So poll option is not there in the thing. Mansiji, can I have the polls, please? Poll option. So try to answer. Mansiji, hello. So in between, you can try to
Yeah,
answer.
just a minute. I'll just give you the right.
Yeah, okay. So let's brush up the basics, which we had been studying in the basic first year of MBBS. Which one of the following is found exclusively in the peripheral nervous system? So nervous system just doesn't mean neurons alone. It has other cells also, that is the supporting cells of the nervous system. So try to answer this question. Which one of the following is found exclusively in the peripheral system and not in the central nervous system? Yes, all those who are present are answering. Well, yes. Exclusively, yes, you have answered it rightly, correctly. That is Schwann cells. Schwann cells are the ones which are exclusively present in the peripheral nervous system. And the Schwann cells actually forms the covering of the axon sheath of the peripheral nerve. It has got its own importance because any problems within this peripheral nerve sheath covering, that causes a lots of diseases within the peripheral nerve. And further, axonal loss also causes a different type of disease pathology within the nerve. These are the main two types, that is axonopathy and demyelinating type of diseases within the peripheral nerve. So that is the importance of Schwann cells. So what the supporting cells are basically of 5 types, both in the CNS and PNS. They are astrocytes, the microglia, the ependymal cells, oligodendrocytes, and the Schwann cells. So Schwann cells are basically the counterpart of oligodendrocytes in the central nervous system, and they form multiple wraps or coverings around the peripheral nerve axons. So a single Schwann cell will be dedicated for a single axon. That is but in the oligodendrocytes, the scenario is different. A single oligodendrocyte will be able to cover multiple nerves within the central nervous system. So that is the difference between oligodendrocyte and a Schwann cell. So with that introduction, let's try to answer one more question. That is, which is an incorrect statement among the following? Glial cells, unlike the neurons, have a capacity to regenerate, whether it's true or false. And second thing would be whether the oligodendrocytes, which we had discussed earlier, forms a myelin sheath around nerve fibers in both peripheral nervous system and the central nervous system, and whether many Schwann cells wrap around a single peripheral nerve fiber. And you know that there are two types of peripheral nerves, the one which are myelinated ones and the one which are unmyelinated ones. And if whether the unmyelinated peripheral nerves lack Schwann cells. So which is an incorrect one? Actually, this question has got two incorrect answers. So if I say that oligodendrocytes form myelin sheath around nerve fibers of CNS, that was the option, then that is the wrong option. One more wrong option is there. I want you to answer that. Which one would be the answer? So definitely oligodendrocytes, I have told you earlier, is present only in the CNS, mostly in the CNS, CNS, and the counterpart of that oligodendrocyte in the peripheral nervous system is our Schwann cell, which forms myelin around the peripheral nerves. So,
Dr. Subir, just one thing I'd like to announce is that whoever wants to participate in the poll will have to have the Zoom app on your phone or on your laptop, and only then you will be able to participate. So I think there are some people who are messaging in the chat the answers. I mean, right now what you asked, the second option, that is all right. But even
yeah,
for the first poll,
yeah.
they've answered in the chat.
Okay. They may not be knowing, they may not be seeing, maybe.
No,
Okay.
everybody who has the app, once you activate the poll, they will definitely be able to see the question. That is for sure.
Okay. So this, by mistake, I have two answers in this option. So the thing I wanted to convey was that in case of unmyelinated nerve fibers, you may think that there are no Schwann cells covering around the unmyelinated nerve cells. It is not so. In case of unmyelinated nerve cells, they have a Schwann cell around them, but the Schwann cells in case of unmyelinated nerve fibers won't be having myelin sheath around them. That is the only difference. All the peripheral nerves will have Schwann cells, but the myelinated ones, that is myelinated ones, will have multiple layers of myelin covering produced by these Schwann cells, but the unmyelinated ones will have a Schwann cell, but without myelin covering. That is the only difference. So this is the Schwann cell here with the covering here, and Schwann cell with multiple wraps. So Schwann cell have, after forming a multiple wraps around the myelinated covering, the nuclei will be pushed towards the periphery, and this is called what is called a neurolemma. Neurolemma. And what is the significance of this myelination? The myelination increases the conduction velocity or the transmission of the impulses within the nerve fiber. So that is why what we call saltatory conduction, that is the jumping of the impulses across the nerve. So what are the important supporting cells, functions of these supporting cells? Astrocytes, as the name indicates itself, they are the stars of the nervous system. They are the large ones. They give nutrition to the nerves, and they form the blood-brain barrier within the CNS. And the microglia are very small ones, and they are concerned with phagocytosis. And ependymal cells line the ventricular cavities producing CSF, and oligodendrocytes and Schwann cells produce myelin sheaths, one in the central nervous system and the one in the peripheral nervous system. I gave importance to these cells, supporting cells, because they support and they are more in number than the neurons when compared to the neurons within the central nervous system. So that this is what I was telling. Oligodendrocytes, a single oligodendrocytes will be covering multiple Schwann nerve cells, nerve axons in the central nervous system, and a single Schwann cell will be dedicated to a single axon. But a single peripheral nerve can have multiple Schwann cells as such. So myelination type 1 is in the CNS and type 2 is in the peripheral nerve. So that was regarding the myelination. So which one of the following you have been studying in physiology, basic physiology, that is the Erlanger-Gassers classification of peripheral nerve. That is, they are of type A, B, and C, and A is divided into beta, alpha, beta, gamma, and delta. It is based on the size of the nerve. So larger the diameter, the larger the speed of the nerve. That is, the larger the velocity of the nerve. And the larger the velocity is better the conduction and faster things happens within the nerve. So you know about this. So which is the motor to the muscle spindle? Which nerve carries the motor fibers to the muscle spindle? So you can try answering by recollecting your first year basic uh, physiology question. Which one of the following nerve type, according to Erlanger-Gass's classification, is motor to the muscle spindle? Try to answer this. So before coming to the peripheral nerve pathology, it's better you have some idea regarding the basic anatomy, physiology, and pathology of this nerves. Then it will be very easy for you to understand the disease rather than by hurting the disease type like Guillain-Barré syndrome, diabetes mellitus affecting and all. Yes, A alpha is the largest one. C will be the smallest one, and A fibers are mostly myelinated ones, and here the A gamma will be the one which carries motor to muscle spindle. So what myelination does is it causes saltatory conduction. There is that in between the nodes of Ranvier, there are sodium channels. So there is jumping of impulses. So it propagates faster. But in case of unmyelinated nerve fibers, you can see that it takes more time because there is no insulation or covering with the myelin. So it takes more time. So that is why these A fibers have more of myelin and the C fibers less of myelin, and are also simultaneously smaller in size, and hence it takes more time. So if you see so this is a pictorial representation of myelinated and unmyelinated. The unmyelinated takes more time, and the myelinated by the time. So that this is the classification. If you see the velocity is 120 millimeter per second in case of A alpha. Simultaneously, the velocity will be less than 2 in case of C fibers. So that is the importance of myelination, and the myelination is aided with the help of Schwann cells within the peripheral nervous system. So the disease pathology within the peripheral nerve could be of multiple types. Mainly we say it is axonopathy, which affects the axon, that is the main stem of the peripheral nerve, or the covering of the axon sheath, that is the myelin, that is demyelination. So which is the most common pathological reaction of the peripheral nerve? What I meant is, which is the most common pathological entity which affects the peripheral nerve? Commonly, which is the one? Is it Wallerian degeneration? Wallerian degeneration occurs after a nerve becomes injured. Is it that? Or is it axonal degeneration or axonopathy or neuronopathy? Neuronopathy means the cell neuron, as you know, it has got a head or the soma or a perikaryon. It can also get injured or damaged. Then we have what is called neuronopathy. Or is it demyelination or segmental demyelination, as we see in many diseases like Guillain-Barré syndrome, which is more common in case of a peripheral nerve. So this is a direct wording I had taken from Bradley, and it is actually a common question which could be asked. New Bradley is out, so this is from New Bradley I had taken. Yes, most of them have answered this as Wallerian degeneration. But the answer I would like, Wallerian degeneration is a secondary process. It could happen or may not happen after an axonal degeneration. So a nerve after an injury, after a lag phase, the nerve may go in for a damage control by Wallerian degeneration. But the most common pathological reaction of peripheral nerve is definitely axonopathy, because of most common cause is actually axonopathy. And so these are the 4 types of pathological processes, or 4 main categories of pathological processes described in the peripheral nerve. So one is Wallerian degeneration, which occurs in response to an interruption, and axonal degeneration, and then is the neuronal degeneration, then is the segmental demyelination or the myelinopathy. So after a lesion, as this is axonopathy, there is Wallerian degeneration, and some regeneration of or sprouts from that degenerated axons occurs. And Wallerian degeneration is occurring after a lag phase. That is why initially after an injury, if you take a nerve conduction study, there may not be any problem within the nerve conduction study. It will be absolutely normal. It may take up to about 10 to 12 days for some changes to occur. So in Guillain-Barré syndrome, that is in demyelination, what happens is that the sheath gets damaged. That is, the myelin gets lost and it's replaced by multiple myelin sheaths. So what happens is, because of repeated remyelination and demyelination, there is multiple knots of Ranvier occurring here, this region, multiple knots of Ranvier. So it has to jump multiple times so that velocity is slowed even after improvement. Or in case of any demyelinating disease, the demyelinating disease improves. So demyelinating disease, the prototype is actually Guillain-Barré syndrome. And in case of axonal disease, the prototype is basically diabetic peripheral neuropathy. And as you can remember that demyelinating disease, there is actually, because of the remyelination and demyelination, the nerve becomes thickened and we have what is called a onion bulb-like appearance in case of demyelination. So demyelinating disease are more prone to have a thicker type of nerves in case of demyelinating disease. And demyelinating disease, as you know, it occurs in case of large fibers. Large fibers are mainly myelinated ones. So demyelination basically affected large fibers, and large fibers are the ones which which helps in carrying the reflexes, which carries the dorsal columns, means joint position and vibration sense, etc. So the demyelinating diseases affect these kinds of peripheral senses as well as reflexes earlier, while the axonal injury with the preserved the myelin sheath won't affect reflexes or these kind of sensations. But that is the thing. So prototypes, remember, and it will be easy for you to understand. Demyelinating diseases, remember as Guillain-Barré, and the axonal type, remember as diabetes mellitus. So Guillain-Barré syndrome, as you know, it is actually rapid or acute to subacute, while axonal is actually a chronic origin. And it is actually more proximal rather than distal in case of demyelinating versus axonal. So last class, I had shown you regarding this case. The patient was having severe sensory ataxia. So this is actually while closing the eyes. If you see when patient was made to close the eyes, the ataxia severely increased. Was disproportionate ataxia while closing the eyes. So this suggests actually sensory neuronopathy. So we are discussing axonopathy, which is correction by Wallerian degeneration. That is the body's technique to regenerate. Then we have the demyelination as in case of Guillain-Barré syndrome. Then there is the sensory neuronopathy. That is the head, that perikaryon gets affected. That could be, as shown in the last case, last week, it could be due to multiple causes. Could be paraneoplastic, autoimmune, toxic, as in case of pyridoxine toxicity, platinum-based chemotherapy, due to infections. And that case, the patient had hepatitis C positive. The case which I had shown you had hepatitis C positive. And so that was regarding the pathology. So we discussed regarding physiology of nerves, types of nerves, the pathology which could affect the nerves, and read from the book regarding in detail regarding these things. All the following are clinical clues for demyelinating peripheral neuropathy, except. So which are the clinical clues? Patient comes with following history, and all of these four would suggest demyelinating type of peripheral neuropathy, except one of these. So which one do you think is not an example of a history of a patient presenting with a demyelinating type of a peripheral neuropathy? Think and answer, because I have given you example and told you all the things in the previous few slides and discussions till now regarding all the possible things. So yes, most of them have answered it correctly. All of you are listening carefully. Very good. Yes. This temperature and pinprick sensations are carried on by the smallest fibers and the unmyelinated fibers, A delta and C fibers. And hence, the demyelinating illnesses usually mostly spares this temperature and pinprick sensation. So that is why in demyelinating peripheral neuropathy, there is pairing of temperature and pinprick sensation, and there is more involvement of joint position. That is, the larger fibers with myelin, that is joint position and vibration and other sensations are most commonly affected. And I had told you before, the reflexes which are carried by large fibers with myelin are earlier lost in case of peripheral neuropathy. And I told you that there is continuous remyelination and demyelination. That is why there is an onion bulb formation. And that is why demyelinating disease, there is high probability that the patient may have an enlarged nerves in case of a demyelinating disease. And you know that the axonal involvement is the most common cause of a muscle atrophy, that is muscle atrophy. But in case of demyelinating illnesses, the axon is perfectly intact, and hence there is less chance for an muscle atrophy, or there will be only a minimal atrophy. After a chronic demyelinating illness only, there will be atrophy in case of a demyelinating type of peripheral neuropathy. So usually there is pairing of temperature and pinprick sensation in case of most of the demyelinating peripheral neuropathy. This is how we apply what we learned in the theory to the clinical aspect. So this is what I have written. So axonal type will have more of distal. You take diabetes mellitus, distal length dependent. It's otherwise called dying back neuropathy. There's a slow evolution. The prototype is diabetes mellitus. Keep always diabetes mellitus in your mind. There will be dysesthesia, distal weakness, pain and temperature more affected. That is the opposite of what in case of a demyelinating neuropathy, and more of distal weakness. Demyelinating, think of as a Guillain-Barré syndrome. And case of neuronal, you can see that it's non-length dependent, and things are rapid. You remember the case which I had shown you the last week, ataxia, and just briefed you in this this session with a video. There will be severe ataxia and paresthesia. Vibration, joint position, Romberg sign will be severely positive in such a patient. And axonal reflexes will be relative preserved, and demyelinating reflexes will be earlier affected. And also, when we do a nerve conduction study, we'll be perfectly able to differentiate between, most likely we'll be able to differentiate between a axonal involvement and the demyelinating type of neuropathy. So that is the importance of nerve conduction study in case of peripheral neuropathy. So if you are working as a consultant or as a general practitioner, you would have come across lots of peripheral nerve diseases, but all will be patients will be coming with paresthesias and numbness, and will be treating with multivitamins and gabapentin. So this, I hope this session will help you differentiate between an axonopathy and a demyelinating disease clinically, with the help of reflexes with all these clinical scenarios which I am explaining. So let's see the nerve conduction study. It's very important and imperative for you to know the nerve conduction study. So just the basics of nerve conduction study. Which one of the following nerve conduction studies suggest an axonopathy? So we're discussing about axonopathy. So, and demyelinating diseases, and also the neuronopathies. So axonopathy, demyelinating disease, neuronopathy. So in this question, I'm asking you, which of these four would suggest a axonopathy? Excellent. Most of them are answering correctly. Yes, I think you have near 100% answer, correct answer, right answer for this question. Good. Everyone can attempt. Then only you'll know the mistake. Very good. Yes. Good. Happy to see most of you answering correctly. But let's see more about the concept. The answer is actually decreased CMAP amplitude. So till now we were studying about demyelination and axonopathy in detail, and telling this basics in detail because it helps you to differentiate between diseases. Diseases you will be able to read from textbooks. So in nerve conduction, what don't if you have time, you can read through the nerve conduction studies from the books and all. The basic thing is that what you do in a nerve conduction study is you stimulate one part of a nerve and get the impulse from the other part. You get the output from the other part. You take the stimulus from the other part. So what you do is that you find the velocity, find the time taken from the impulse that is stimulus from one part of the nerve to reach the other part. So you took the time and you know the distance already. And what we see is actually the velocity. You already have seen that in the demyelinating disease, where the myelin sheath has got damaged, the velocity will be, that is speed will be very much decreased. So the time taken will take more time. So if it was 3 minutes, 3 minutes earlier, it will roughly tell, it means I am just, for comparison, I am telling if 3 minutes earlier, it will be taking 6 minutes now. So the velocity will be severely reduced in case of a demyelinating illness. So it will be more reduced in case of a demyelinating illness. So conduction velocity will be reduced in case of a demyelinating illness because the time taken by the impulse which we have given in the nerve conduction study will be taking more. But in case of an axonopathy, there is nothing wrong with the myelin sheath. Only the axon is lost. So the stimulus which was given, has to produce an amplitude. But this amplitude is not able to produce enough energy to fire multiple nerve impulse because nerves axons are cut off. So here axonopathy, there is decrease in amplitude. So but the velocity and the velocity will be perfectly normal. So just understand that velocity is decreased in case of demyelination, and in axonopathy there is decrease in amplitude. So we'll discuss. So that's just the simple formula, distance by time, nothing more to remember. And in case of amplitude, you know that you are giving an impulse to one part of the nerve. So it has got multiple nerve fibers, multiple types of nerve fibers even. So if that number of nerve fibers are cut due to axonopathy, it is unable to produce a estimated compound action potential. So the amplitude will be reduced, but conduction velocity and latency will be normal. And since there is delay in time for the stimulus to reach the particular time, distal latency will be prolonged and conduction velocity will be reduced in case of demyelinating illness. And this will be the shape of a sensory nerve action potential, and this will be the shape of a compound muscle action potential. So I think that is pretty clear, just to understand, make you understand what is happening within a nerve conduction. So what we look at is actually latency, uh, conduction velocity, and amplitude. Axonopathy, A for A, amplitude will be reduced. Just remember that A for A, amplitude will be reduced. So what was in the option you saw? F wave. So just for you to understand what an F wave is. Which among the following is not a late response in nerve conduction study? Those who know the answer can attempt. Otherwise, it's not an issue. You'll just which one of the following is not a late response in a nerve conduction study? So we stimulated one part of the nerve, we got the response immediately. So that is how we took the latency, conduction velocity, amplitude, etc. That was our response. But some responses occur late, or we take the late responses in case of nerve conduction study in some scenarios or conditions. So which one of the following is actually late response, and which is not a late response? Yes. So still most of them are answering correctly. So read the question carefully. You may think that F wave is not a late response. F wave is the usual late response which we look into in case of a nerve conduction study. So M wave, this is actually the normal motor response in case of a CMAP amplitude, which we look into. This is the other name, M for M, motor response, which is the usual one which we look into. H reflex is otherwise called Hoffman's reflex. H for H, Hoffman's reflex. It is actually a late response because when we stimulate a part of a nerve, it can go either antidromically or orthodromically. That is, it can go either ways. What we look into is actually orthodromic contraction. That is, we want the response, but it can go backwards to the spinal cord also. That is, towards the spinal cord. So that it goes back to the spinal cord, goes one turn and comes back. These types of reflexes or waves are called late responses, which occurs after the M wave. So M wave is actually our immediate response, and all the others are the late responses, of which Hoffman reflex is one, which is mainly a sensory reflex, and which is a true reflex. Its corresponding clinical counterpart is what is called the angle reflex. That is also one more question. Its reflex counterpart in our clinical scenario is actually a ankle reflex. So H reflex corresponds to ankle reflex. And F wave. So F is actually, this wave was first studied in the foot. That is why F wave is called F wave, F for foot. So F wave is also actually, when we stimulated the nerve, one part went forward to the recording area. We got the response, orthodromic conduction. When it went backward to the spinal cord and came back to give a response, that is called F wave. So the problem is that in demyelinating illnesses, what happens, because there is increased myelin loss, there is actually prolongation of the F wave. So we look carefully in this case, in such scenarios, for F wave prolongation. That is why demyelinating illnesses have prolonged F waves as such, as in case of Guillain-Barré syndrome. A wave is also similar kind of reflex, which falls in between F wave and M response. So that is other wave, that is axon wave. So H reflex is actually one of a true reflex. F wave and A wave are actually pseudo reflexes. So remember that also. So H reflex counterpart is actually ankle jerk. These are the MCQs which could come from these kind of late responses in case of nerve conduction studies. With this basic idea, if you want to read, you can read from the other textbooks regarding nerve conduction studies. So axon response, I told you, it is between M response. CMAP, normal CMAP is, this is the M wave. This is our immediate response. This F response is the late response. Axon reflex falls in between them. So this is what happens in that. Which one of the following toxins causes segmental demyelination predominantly? So we have the pathologies: axonopathy, demyelination, neuronopathy, Wallerian degeneration. You should understand that toxins basically causes axonopathy, and one of them causes, exceptions are the ones which could be usually asked for the entrance exam. So which one do you think is actually, it's a pretty easy question because it's a clinical scenario question, a clinically relevant question. So you could be able to answer, but you are making it wrong, getting it wrong. It's pretty simple, I think, clinical scenario. If you think okay, try once again. Which one of the following toxins cause segmental demyelination predominantly? So all toxins causes basically axonopathy, but some exceptions are there, most likely, like, so answer is actually diphtheria toxin. Diphtheria toxin produces a Guillain-Barré-like syndrome, but Guillain-Barré, it's actually ascending paralysis. Diphtheria causes kind of a descending paralysis. So which one of the following causes, so other options here, organic mercury compounds, doxorubicin, high dose pyridoxine, etc. causes not an axonopathy, it's rather causes what is called, what we are discussing, that is actually a neuronopathy. It's not axonopathy, it's neuronopathy. That is, the nerve head is affected. Basically, the sensory neuronopathy occurs. The patient gets severely ataxic, sensory ataxia, sensory neuronopathy. Diphtheria causes a demyelinating type of cell. Just see this case scenario. Read through this case scenario. An 18-year-old boy presented with facial diplegia, that is bilateral seventh nerve weakness, and predominant upper limb motor polyneuropathy. His nerve conduction study showed a mononeuritis multiplex pattern. He was a painter by profession, and he has been painting for past 2 years and has been having recurrent episodes of abdominal pain. His oral examination revealed the following findings. So he was a painter by profession, recurrent abdominal pains, and he has upper limb predominant motor. He doesn't have any sensory symptom, just a motor symptom. And a nerve conduction study revealed this following finding of upper mononeuritis multiplex kind of pattern, that is confluent, that is multiple nerve roots. So this is actually a factual case I have put. This case is important to show you importance that please don't jump into answering the scenario questions, lengthy scenario questions. I have put a video of how to be careful while answering questions in case of attempting, especially institute exams, because that there such institute exams will be having questions where they want purposefully they want you to answer the wrong option, and that will be the first option. That is why painters etc will be given in the option. So now people are giving it correct because it's pretty obvious that picture there has been obviously kept. So you didn't even look into the picture before answering. So that is actually, otherwise, see the picture. See the picture there. Everyone try to answer. So very important. Read the question again and try to answer. So all the all this peripheral neuropathies are basically basic common things you will be knowing. But this rare things you have to know, because rare or which are actually separated or very uh, not that common things, you have to keep in your mind or have to make a list of it, because they are the ones which will be coming to you as an MCQ. So most of them have answered it. 37 of them have answered. Good. Most of them have answered it as wrong, as lead. So I'll tell you one thing. What you see here in this option is the oral cavity examination. You can see this is actually an enlarged tonsil. This is an orange yellow tonsil. So if I had told you this, you would have answered it as single answer. You all must have known the answer. That is, what is it? It's actually Tanger's disease. But in the clinical scenario, what you had is the painters painting this paints nowadays doesn't have lead in it. Previously, way back only they had lead in it. Now it doesn't have. And Tangiers also presents with all these kind of symptoms. So the answer for this is actually not lead toxicity or acute intermittent porphyria, or it's actually Tangiers. It's rare disease. Only 100 to 200 case reports are there. It's for so Tanger's disease, you know that the HDL cholesterol levels will be less, and the characteristic finding is actually the patient having the orange yellow tonsil and hepatosplenomegaly and other findings. So these are the tables or the boxes which you need to know. These are boxes from Bradley. So with the peripheral neuropathy is actually a motor sensory syndrome. So what are the exceptions? That is neuropathies with pure motor manifestations. As in case of lead intoxication, the patient will present with actually a finger drop or a wrist drop. And Charcot-Marie-Tooth, even though it is a hereditary motor sensory neuropathy, patient won't have any sensory findings or sensory problems. It will be basically a foot drop to present with. And that things you should know. And the polyneuropathies with predominantly upper limb motor involvement. You know that the peripheral neuropathies have a stocking and glove pattern. It's not glove and stocking, it is stocking and glove pattern. So stockings are the ones, socks like things we wear in the lower limbs. So it's actually stocking and glove pattern. When there is an exception, that is predominantly upper limb involvement, there is severe motor weakness in the upper limb involvement, it can help you localize to a very few conditions. Example is, one of them is actually multifocal motor neuronopathy with conduction block. So MMNCB. It occurs in young males with predominant upper limb involvement, and MADSAM variant of CADP. Lead neuropathy, that is, the patient will present with finger drop and wrist drop, porphyria, Tanger's disease, and familial amyloid neuropathy, etc. And the neuropathy patient presenting with facial nerve involvement. GBS, 50% of them can present with bifacial involvement, Lyme's disease, here also Tanger's disease. So even if there was no uh, orange tonsil, you know that this is the overlap. Tanger's disease can have bifacial involvement, predominant upper limb involvement, and in this case, we also had a orange tonsil. So this is actually the way you should study these tables in case of peripheral neuropathy, because tables with kinds of exceptions where you don't get a pure usual sensory motor syndrome, you have to keep in mind. So this is actually usual. This is a question you try to answer. So in case of toxins induced peripheral neuropathy, or due to conditions like the giant axonal neuropathy, what will be the clinical presentation of the patient? That is the external features of the patient. What do you think? Actually, match the following. I have put it in the as a match the following question so that you get the maximum yield out of the question. Yes, excellent. Uh, those who have answered in the one go has answered it correctly. Okay, good. Yes, good. Rest of them, it's okay. Let's sit back and listen. So, some clinical finding, that is always in peripheral neuropathy, you have to go for a head to foot examination. You may get clues, as in case of leprosy, as in case of other conditions like this, thallium poisoning, there will be alopecia. So the answer here in this condition is actually in giant axonal neuropathy, what you get is actually curly hairs. And the patient will be having other signs like cerebellar signs, nystagmus, etc. Along with it. And rest of disease, the patient, that is, the patient will be having retinitis pigmentosa and also what is called ichthyosis, dry scaly skin. And in case of Fabry's disease, there will be angiokeratoma, that is angiokeratoma corporis diffusa. That will be present in case of Fabry's disease. So I think we discussed all of them. Thallium will be having alopecia. Now, arsenic poisoning also will be having this thing, that is in such condition, peripheral neuropathy, and in such condition, the patient will be having Aldrich-Mees lines. So A for E, that is Mees lines. So the full name is actually Aldrich-Mees lines. So you can remember that. So this is also one table you need to remember. This is from Bradley. So arsenic, again, Mees lines. Giant axonal neuropathy is with curled hair. Okay, so there are many patterns of weakness given in Bradley. Study the patterns of weakness which are given in Bradley. So asymmetric proprioceptive sensory loss without weakness. So this is our case which we had seen earlier. So this is one pattern of weakness. What do you think is this question we have discussed earlier? So you can easily answer this question. So this question I had put just for you so that you read the other patterns of weakness. So there are 10 patterns given in Harrison in a box. You can read them. Asymmetric proprioceptive sensory loss without weakness in case of peripheral neuropathy. We had discussed, I had shown you a table before. But small things we have to be careful of. That is why this question has been put. So it's actually, yes, most of them have answered it correctly. It's actually vitamin B toxicity which causes this sensory neuropathy and not deficiency. So read that table. So this is the table. It's vitamin B6 toxicity which causes sensory loss rather than deficiency. So peripheral nerves will include mononeuritis, polyneuritis, generalized symmetrical peripheral neuropathy, plexopathy, etc., etc. So let's see how you answer this question. Patient often complains of an acute or subacute onset of pain in the forearm. He is unable to flex the distal phalanges of thumb and index finger, making it impossible to form a circle with those fingers. Thumb and index finger. So thumb and index finger, he is unable to do so. That is form a O sign. That is otherwise called OK sign. He is unable to form a OK. This is otherwise called OK test. So which nerve do you think is affected in this patient? So is it this is question number 12. So this question I put so that you read all these nerves thoroughly. So you, while revising your portion, you may miss these nerves. That is radial, median, ulnar, this musculocutaneous, axillary, etc. nerves, which you are supposed to learn in the anatomy. You may miss while ticking out all the nerves. So you should cover it while reading the peripheral neuropathy part. It comes under peripheral neuropathy. Okay. Yes. So, yes, most of them have answered it correctly. So the expected answer in this case is usually in the option you would get anterior introitious nerve. Anterior introsious nerve is the one in which there will be difficulty in doing the OK sign. And anterior introsious nerve is a branch of median nerve. So this is what is abnormality. You won't be able to make a perfect round in case of an OK sign. You will be able to do only like this, not like this. So that is the anterior introsious nerve. It's otherwise called Kilo-Nevin syndrome. It's an entrapment syndrome. So peripheral nerve, while dealing with this, it is classified as neuropathy, mononeuropathy, plexopathy, radiculopathy, multiple mononeuropathy, polyneuropathy, and polyradiculopathy. So divide the topic like this and read between basically Harrison or Bradley from that. So what is the proposed cutoff? So we learned about conduction velocities. In demyelinating disorders, there is decreased conduction velocity, and in axonal diseases, there is no change in conduction velocity. So you know that Charcot-Marie-Tooth disease or the HMSN, hereditary motor sensory neuropathy, has got multiple variants. So in differentiating this, we look at basically the conduction velocity. And in conduction velocity, we basically look at the upper limb conduction velocity. That is basically in the median and the ulnar nerve rather than the lower limbs. Because lower limbs you will be usually affected by other diseases. So in that case, to differentiate between these two types, that is axonal and demyelinating type, what is the cutoff used for that? So normally in adults, it will be roughly around 50 meter per second. If you look at your conduction or mine conduction velocity, it will be 50 meter per second. So what do you think will be the cutoff velocity below which we will call it as a demyelinating and above which we will call it as an axonal variant? So those who know the answer can give the answer. It's very important. It's not that it's unimportant. These values are unimportant, because based on this value, we are going to differentiate between a very important entity, whether it's axonal or demyelinating. You know that we have other clinical criteria. There is reflexes, there is nerve thickening, etc., and other findings which will help you. But conduction velocity in a nerve conduction study helps you a lot. Yes, excellent. Most of you have answered it. But you may have in your mind that whether it's 35 or 38, right? Yes, in Harrison, the value is given as 38. Could be 38 or 35. The latest Bradley, which was released, the hard copy hasn't been released, but it will be released in May. The latest copy shows that it's 35. This is the wordings from Harrison. So that is 35. You needn't worry about this 38 or 35. You just need to know that if it is below such a value, that is 35, roughly 35, you know that it's kind of a demyelinating illness. And above 35, you know that the axons are the one affected and myelin is intact. So CMTs are the high yield topics in case of a peripheral nerve rather than any other topics. So toxin-induced CMTs and Guillain-Barré syndromes and CIDP will be forming the most of the questions in case of peripheral nerves. So which among the CMTs has a progressive childhood onset? Which among the CMTs has a progressive childhood onset? This is a very simple question. You must be already knowing, and you must also already known the name of the disease also. So type 1 CMT is otherwise known as a demyelinating type of illness. Type 2 is otherwise a axonal illness. So type 1 and type 2 differentiating, we used the nerve conduction study. 35 was the cutoff. Type 3 is otherwise called Dejerine-Sota syndrome or Dejerine-Sota disease. This is actually severely demyelinating disease with a conduction velocity of less than 10. So it's very severely demyelinating disease. It occurs at the very young age group. And type 4 is actually autosomal recessive type of illness. So that is correct. Most of them have answered it correctly. It's actually CMT3. So it's an uncommon, very rare, progressive hypertrophic neuropathy. There will be definite, because severely demyelinating, so you know there will be hypertrophy of the nerves. And motor development is delayed. It is not autosomal recessive, it was previously thought. So the autosomal recessive type of CMT basically is type 4. That is also one of the MCQs. CMT1 and 2 are autosomal dominant. 3 is actually sporadic rather than dominant or recessive. So 1 and 2 dominant, 3 is sporadic, 4 is recessive. Which of the, so CMTs you need to do know a bit more in case of institute exams. So read through the tables within Bradley and Harrison. Which of the following CMTs or Charcot-Marie-Tooth disease are predominantly occurring due to duplications? So if you look at the incidence of CMTs, the most common CMTs occurring are the demyelinating type. And most common of the demyelinating type is actually CMT1A. So which of the following CMTs are predominantly occurring due to duplications? So try to answer this question. If you are read through the table or read through Harrison, you will be able to answer. HNPP is actually hereditary neuropathy with liability to pressure palsy. You keep the hand while studying or sleeping at one point, and you get a numbness or weakness at that pressure point. That is liable. That is the hereditary liability to pressure palsy. It is otherwise called tomaculous neuropathy. Tomaculous neuropathy. That is actually finding in nerve biopsy you get. So I'll tell you. So you have to CMT1A is actually the correct answer. Duplication. Most of the CMTs, that is number, it's not based on the incidence or what you get in the clinical scenario. Most of the CMTs are due to point mutations. But the most clinically, what we get is actually most common CMT is CMT1A, and it is due to a duplication, due to PMP22 duplication. And when the same PMP22, when it gets deleted, what we get is what is called HNPP. This one, HNPP. So this is the table from Bradley. I divided the table into 3 parts for you to for your simplification. So CMT1A, I told you, it's actually CMT1A. It's actually PMP22 duplication. Others are actually point mutation. PM is point mutation. CMTX is actually X-linked one. And this is actually CMT2, that is axonopathy. You needn't remember that. And PMP22 is actually the more of deletion rather than point mutation. This is actually not needed much, Dejerine Sota and type 4. So concentrate on the first 2 parts rather. These genes and all are also a bit important. If you can, you'd read, especially those preparing or aiming at institutes, you definitely need to read that part. Which of the inherited peripheral neuropathies have been associated with vocal cord and diaphragmatic paralysis? This question I have taken directly from Harrison to make you understand that these kind of questions could be asked because it's there in Harrison. You need to know. Because some notes you would have to prepare from Harrison regarding these odd points in case of Charcot-Marie-Tooth disease. Okay. So these are actually the clinical features. CMT table, study important features from the CMT table. CMT1A is associated with deafness. CMT2A is associated with optic atrophy. And CMT2B is, LGMD associated with LGMD1B. And vocal cord and diaphragmatic paralysis is associated with CMT2C. And 2D is kind of a spinal muscular atrophy type 5 type. And CMT4 is congenital hypomyelinating neuropathy. So make a table from Harrison. So if you want, and the next is actually acquired type. So differentiating this acquired and hereditary neuropathy by a nerve conduction study is whether the patient has actually a conduction block. So which is the most common antibody present in Miller-Fisher syndrome? So this we will be able to answer, I guess. I want everyone to answer this question. This is the most common antibody present in Miller-Fisher syndrome. This is actually a demyelinating illness, variant of Guillain-Barré syndrome, which will have ophthalmoplegia, ataxia, and neuropathy. So you shouldn't go wrong in this. Yes. Yes, it's actually GQ1B. So antibodies in Guillain-Barré syndrome, you need to know that is AIDP, acute intermittent acute demyelinating polyneuropathy. You need to know. So if I put this, what will be your answer? Question number 18. Which is the most common antibody present in Miller-Fisher syndrome, apart from anti-GQ1B antibody? This is the importance of studying table in detail if you are preparing thoroughly, if you want to prepare thoroughly. Okay. So apart from GQ1B, it's GT1A, which is more common in case of Miller-Fisher syndrome. So sparing of which nerves in electrophysiology differentiates GBS from other length-dependent neuropathies? So you know that all the nerves will be affected in case of Guillain-Barré syndrome. But which of the following nerves will be preferentially spared, and which is thought to be 100% specific, more than 80% specific in case of Guillain-Barré syndrome? And if that nerve is affected in case of a patient suspected to be Guillain-Barré syndrome, we have to think of other causes, or we have to suspect other diseases. Don't think it's facial. About in Guillain-Barré syndrome, 50% can have facial nerve involvement. Median definitely can get affected. Sural sparing is what we look in case of AADP, that is demyelinating type of polyneuropathy. Now studies are telling that even axonal variety can have is known to. It's not studies are saying it's known to have sural sparing. So that is regarding. So this question I have taken directly from everybody. Those who are reading have read Harrison thoroughly. Hope you have seen this question. I have put this question so that nobody misses such kind of questions also. This drug is used, that is tafamidis meglumine, is used. Yes, 7 of them have read Harrison thoroughly. No, 11. Fine, good. So Harrison should be read thoroughly because that is the basic book for entrance preparation for MD entrance as well as DM entrance. So that is importance. So you may miss such kind of questions, and this will be a decider question. So that is why I put this question. Yes, those who have answered, I have answered it correctly. It's actually FAP, familial amyloid polyneuropathy. This is treated with tafamidis meglumine. So with this, I think I was able to give you a brief review about peripheral neuropathy, peripheral nerve disorders. I'm sure I was not able to complete all the portion, and that is also not my intention. I want you to read this Harrison as well as the Bradley portion of peripheral nerves. Emphasize more on Charcot-Marie-Tooth disease, Guillain-Barré, AIDP, the variants of AIDP, CADP variants, and toxins, toxic induced peripheral neuropathy. That is the most high yield portion of this vast topic of peripheral neuropathy. We'll go into the advanced portion of peripheral neuropathy in the next class, next module. So I hope you were able to understand the basics of peripheral neuropathy. With this, I'll end this session. Thank you. Thank you, everyone. Thank you. So any questions? I'll just check. Length-dependent neuropathy is actually the long nerves are affected first. That is the large lengthier nerves are affected first, and the uh, uh, lengthier nerves are affected first. That is length dependent rather than the short. So length dependent neuropathy, what happens is once the patient's it starts in the lower limbs. So once the patient's peripheral paresthesias or involvement affects the up to the mid calf, it reaches the paresthesias reaches the upper limb, the distal extremities of the upper limb. And when it reaches the upper thigh region, what happens is this paresthesia reaches the chest region. That is the that is regarding length dependent neuropathy. Usually it occurs in axonopathy, especially in case of diabetes mellitus. And non-length dependent is in case of other conditions, especially in case of demyelinating illness and in case of that is neuronopathy. So anything other than length dependent will come under non-length dependent, basically demyelinating and neuronopathy. So that is regarding, and lectures on movement disorders and dementia I have already done, which is there in the YouTube, free YouTube, which is freely there in the uh, YouTube channel. You can just type find neurophilia and it will be there. Why sural sparing in GBS, which GBS. I told you that it's actually more proximal. Even I had looked into it. I'm not sure why it is happening. I just before this lecture itself, I was looking into it. Even I couldn't find the answer for that. Why sural sparing specifically in case of GBS? If I get an answer, I will reply in the next module. Thank you.